Let's talk about telemental health competencies for couple and family therapists. And to discuss this, I'm really glad to have with us Dr. Katherine Hertlein. She is a professor in the couple and family therapy program in the Department of Psychiatry and Behavioral Health at the University of Nevada, Las Vegas, Kerkorian School of Medicine. Across her academic career, she has published over 100 article and book chapters and 12 books. Dr. Hertlein also won numerous awards for research, teaching, mentorship, and supervision across her career. Dr. Hertlein also was awarded the Fulbright Core Scholar Award for 2018 through 2019. She is also the editor-in-chief of the Journal of Couple and Relationship Therapy. She currently maintains a private practice in Las Vegas, Nevada, and she is the lead author of a 2021 article titled Toward Proficiency in Telebehavioral Health, Applying Interprofessional Competencies in Couple and Family Therapy, which was published in the Journal of Marital and Family Therapy. So Dr. Hertlein, thank you very much for joining me today.
Thank you for having me.
Excellent. Yeah. So, I really enjoyed your article because it spoke about the need for bringing on training for graduate students, clinicians, particularly in for couple and family therapy, because of the pandemic. So with the pandemic, everyone had to transition. And you mentioned in your article that historically universities weren't really incorporating that in the curriculum. So it sounds like you really played a piece in helping make that transition for the university that you work with. You saw those gaps ahead of time. You kind of prepared ahead of time. So can you speak about that? What the need was, how you addressed it, what the current need still is?
Mm-hmm. One of the things that has been really important, at least here in the state of Nevada, has been something called workforce development. And the idea was that we need to make sure that we are, as a school, as a unit, as an educational house, that we are training people to be able to work with individuals, not just within the areas that are highly populated, like here in Nevada, but also in maybe the rural areas. So that was one of the ways where we thought about how do we continue to expand our practices to make sure that we're cultivating the workforce in a way that's going to address the needs here in Nevada. And the second thing that happened was that I'm married to a software engineer. And so I've always been quite interested in the interplay of technology and couple and family life, because I've sort of been watching what technology can do. And I've been acutely aware of the role that it has and the capabilities of technology for a long period of time. A third thing is looking at the generation of our students. These are individuals who, yes, are very excited to work in person with their couples and their families and their individual clients, but they also have a very unique skill set when it comes to using technology in ways that maybe I didn't have when I was an undergraduate or a graduate student. So how do we sort of tap into the strengths that our students have? How do we tap into the ways in which technology can link services? And how do we tap into the needs of the community that are going to better serve everybody here? And so that sort of led us down this path of developing telebehavioral health in a way that was maybe more rigorous and a way that we could teach more consistently.
Yeah, so the way you described that makes it super obvious in terms of why it should be part of the training and part of what we're doing in practice. So, people have a hard time getting behavioral health services, right, in Nevada. The students are aware of using technology. They use it all the time. You're aware of the awesome capabilities because of the work that your husband does. So yeah, that all makes sense. So what about the gap, like that it hasn't been done so much, and what the needs still are in regards to that?
I think for a lot of the couple and family therapists, people doing the work, there was a fear around it. We have a high value in relationships. And when you say we can maintain a relationship perhaps just as well or maybe even better when you put a screen in front, that scares people. And I think there was among the couple and family therapy profession, I don't think it was something that people were sort of willing to entertain or engage. I don't think there was a belief that the relationships could be as strong, if not stronger, if we facilitated those sessions over telebehavioral health. And in fact, a lot of the earlier research, not necessarily in couple and family therapy, although there were a few studies in couple and family therapy, but most of them looking at, what are some of the practitioners' responses to couple and family therapy, counselors, social workers, et cetera. A lot of it had to do with the impression that we had that we would not be able to join as well with people online. And because we value relationships, this wasn't going to be something that relational therapists could provide. And I think we learned very quickly that other professions sort of navigated through that, I think, a little bit better than couple and family therapy did. And then as a consequence, we sort of now are the last profession that's really adopting the telebehavioral health elements.
Yeah. Yeah. One thing that I've seen for quite a long time now is the discrepancy between what you're talking about in terms of the clinicians' impressions or their assumptions or their preferences and reality.
Yeah.
Yeah. So I try to get people to look at the facts, like look at the research studies in terms of therapeutic bond and alliance and people and couples being able to connect virtually and stuff like that, and being able to understand the emotional state of the person you're talking to, like put it to the test. Because I think therapists got into this profession in the mindset that they would be sitting in the same room as people.
For sure.
They gravitate towards this profession because they think that's what they're going to be doing and they love doing it. And then they're trained on all the importance of all of that, right? So it's kind of a whole like process of mindset. So yeah, there could be a shift, but not all clinicians, right? There's been clinicians who've been doing telemental health for a very, very, very long time. Freud didn't even have his clients look at him. So,
Right.
Yeah. So, clinicians been doing this for a long time, but not the majority. So it sounds like from what you're saying is that for couple and family therapy, that the profession, that there is a shift going on, that there is much more acceptance and appreciation for virtual work. Is that right? Or
there is now, I think COVID forced it. I think if you look at like 2015, when we were doing some of our early research on this subject, there weren't a lot of people who were practicing over telemental health. And so the best we could do is assess people's perceptions of telemental health, or assess their perceptions of social networking, because people really weren't doing the work. And then around 2020, in March, I remember distinctly, there was a weekend when everything shut down. I was getting called by different universities to set up their telebehavioral health practice over the weekend, because things had shifted that quickly. So now that we've all got our structure in place, our framework in place physically to be able to now conduct those sessions, I think now there's been an understanding and there's been enough time where people who are a little bit challenged by that idea are looking and going, actually, we can provide a pretty comparable level of care despite my initial reservations.
Yeah. Well, that's good to hear. And can we talk a little bit about the benefits of virtual work for working with couples and families?
Sure.
I know a lot of people that work with couples do, especially when the couple's kind of volatile, right? There's a lot of anger and stuff. So, starting off with letter writing, which is kind of like give each other some space here, right? So sometimes they'll start with letter writing, or, there was research that showed that when couples and families would have family meetings or couple meetings over the phone, they were less volatile, right? Because they weren't triggering each other as much to the visual cues, and they can't speak over each other, and then people, live in different spaces and their schedules are difficult. But maybe you can speak to like what love to hear from you. What are some of the benefits of using technology and working with couples and families?
Yeah. So I definitely understand the examples you gave. I also sometimes, when couples are really volatile in session in person, I'll have them sit back to back. So they're
Uh-huh.
not looking at each other. And that's a way to sort of also diffuse the tension in the room. But
Sure. Yeah.
so, from a pragmatic perspective, I think it's important to recognize the accessibility that telebehavioral health provides. We have the ability now to be able to treat people all across their state, independent of whether or not they have, MFTs or have access to services in that area, which is a
Mm.
huge bonus.
Yeah.
A second thing is where the clinicians, I think, earlier had this impression that you could not join with clients as effectively online. The
Mhm.
clients actually disagree. The clients actually say, actually, I can join more with my practitioner because I don't feel completely vulnerable because there's a machine here, right? It actually feels like they can tell us more because from their perspective, because of the device, which is something that I think we didn't expect. Um, a third thing is your ability to be able to help structure some of those sessions. So it's possible to be able to now have really a session where you can have like when I'm working with couples, it's important in the earlier part of my treatment to do kind of an individual assessment for the both of them. So sometimes that might look like splitting the session and having half spend the time with me, the other half spend the time in a telebehavioral health scenario. There's more freedom for that individual to be able to go where they're going to be perhaps more safe. They won't think that their partner is going to be listening at the clinical door, or whatever it is. But now, of course, you can do that in a house. You've got to make sure that you structure well enough. But I think that that's an important point as well. I also think in a lot of ways you can share resources and materials, perhaps in session, a little bit easier by doing links. You don't have to have the website on hand. You don't have to have something printed out for the client. You can very easily put links and resources within the chats, maybe in ways that we couldn't do before, right? Instead of having client, oh, look up this book. I can tell them exactly what book. I can tell them exactly where to get it. I can send them exactly to a direct link in ways that are maybe more efficient. One of the other things that I think, as we were talking about telebehavioral health early on, I would ask clinicians, hey, how many of you do telebehavioral health? And people would not raise their hand. And then I would say, okay, how many of you have exchanged emails with the client or text messages? A large proportion of the room would raise their hand. And I would say, guess what? You're doing TBH. So you have to make sure that your informed consents are going to allow that kind of communication. And my guess is that they don't. So that's what we're here to talk about, right? So I think we ended up in a space where we were able to take clients, or clinicians rather, who were perhaps really practicing telebehavioral health without calling it that, which kind of represents this fundamental ethical problem, right? And being able to make sure that their paperwork was now consistent with the work that they were probably already doing in terms of those telebehavioral interactions they were having.
Yeah. Yeah. And another thing I'm interested in is, have you heard of any studies on the utilization of couple and family therapy um, with virtual services? Because from my experience and talking to other clinicians who also do couple work, work with couples, a lot of times they'll find excuses not to go to their appointment, and therapy
Mm-hmm.
only works if it happens, right, if it takes place.
Yeah.
So yeah, and people have kids and jobs, and
Yeah.
yeah, and sometimes they might not feel so comfortable
Yes.
yeah, going somewhere. Any thoughts on that?
I haven't seen any studies on the utilization. There have been a couple studies looking at how TBH services, in terms of the utilization, you've got ethical issues that need to be managed, and then you've got to, make sure that you're gearing your interventions to whoever's in the room, whether that's individual or couple. In terms of anecdotal evidence of the utilization, I think there are some individuals who see that relationship now as a little more informal. This is, of course, why they join better, right? Because they see it as a little bit more of an informal relationship. On the other hand, We've had some situations where people will sort of text and say, hey, listen, or email their therapist, because I also supervise cases where this has happened, and say, oh, I can't make it. Are you around in an hour and a half? Or like, just things that really don't
Right.
reflect respect for going to a physician's office, which is really what we still do. You have an appointment, there's a time, we have other things to do. I've got a life, you've got, right. So I think sometimes the impression from the public has been that we are sort of always available. And I think that can be really problematic as well. I had a client at one time send me a text message in the middle of the night. So I woke up to this message, but it was their brother's wrist that was sliced. And he was like, oh, my brother tried to kill himself last night. And I was like, what? And his brother was a client of mine as well. So those are the ways that I think clients think that we're like 24/7 available because of TBH, because of
Right.
technology.
Right.
And we're not. Like, you can't do that. You're just give me a heart attack, right?
Yeah.
Ultimately, he was okay. But I think it's challenging to educate the public that we still have a role like a doctor, like a physician, like a healthcare worker, right? We still are that profession, and we have to continue to communicate to the public that that's who we are.
Right. Yeah. Yeah. And that gets into the competencies like you're touching upon that are important for clinicians to be trained on, like how to prepare clients for services, and that informed consent, that onboarding
Yes.
is super important. How to set the boundaries that you want to have for your
Yes.
practice, for your organization.
Absolutely. We didn't do that in person. I didn't call a client in before a session started and say, I'm going to tell you how to be a client. I mean, there were certainly many people who I wish I had done that, but we generally didn't do that, right? In telebehavioral health, you're thinking about doing a tech check with the client beforehand to make sure the technology works. I talk with my students about, well, what's going to be your plan if the technology drops? That has to be communicated with the client. You have to communicate with the client the boundaries. I mean, there's all this other prep work that I think has to take place, which is unusual and different from perhaps how I was trained in a non-TBH world.
Right. Yeah. Yeah. In training clinicians, I found that it's interesting, like with telemental health, a lot of questions come up, and we think, okay, we need to learn how to address these things, such as, how to handle difficult situations. What if there's aggression in the household, or it's not a private location, or their inappropriate behavior, or, a lot of things can come up, or they didn't fill out the paperwork, or they're in a public place, all these things that come up.
Yes, they're in their car driving. Like, why?
Yeah.
I don't know, but they do that, right? So yeah.
You're right. Yeah. But then on the other hand, we have a lot of those situations happen when the client's in the office too. Something inappropriate behavior, aggression, so there's
they might just get up and walk out. Might as well be in a truck. Like, I don't know what's happening. Yeah.
Right.
The other thing I've noticed about couples, which is really, really different for this work, is they don't look at each other anymore. And when I asked a client about it, I said, hey, why aren't you turning to your wife as she's talking to you about this? He was like, well, I can see her in the camera. And I was like, okay, but like, she's not. I mean, that's I think that's different than actually turning in person and being a witness to her pain. So I think couples sort of often take these shortcuts now of, well, I can just see them so I can see them here, so I don't have to look here.
Right.
But let me tell you, you still have to look here. Okay.
Right. I would assume that your coaching probably quickly shifts that. Is that right?
For sure.
Yeah.
For sure. Yeah. Yeah. Hello. We're still okay, but pretty sure that's not. Yeah.
And as the therapist, when you're on video with two people, when you move your eyesight, it actually looks to them like you're looking at them.
Absolutely right.
Yeah.
And the eyes are a little bit different, right? So I'm looking in the middle of my screen, which means I'm looking at you, but it doesn't look like I have eye contact. If I went to do eye contact, I'd have to look at my camera button. Right. Now I've got eye contact. but now I'm not looking at you or the screen. So it's
Yeah.
this weird thing with your eyes where you've really got to pay attention in ways that maybe we didn't before. And I
Right.
think,
Yeah.
maybe that's where some of the early concerns around joining emerged, because you're
Sure.
not quite looking at someone. I'm not sure, but that's something else where, we have to
Yeah.
acknowledge that in the room.
Yeah, and that's part of the training. So for the viewers watching this, one trick for that is if you have a decent sized monitor with the camera, mounted on the top and the middle of it, if you sit 5 feet back from your monitor and you have a pan tilt zoom camera, so you zoom in with
Yes,
your camera, but you're sitting 5 feet back. So when you're looking at the monitor, it'll appear that you're looking at them because it decreases the
absolutely.
gaze angle. Yeah.
Yep,
Yeah.
exactly.
So yeah, getting the right tech, setting up the office, all these competencies would really help the clinician feel more confident and
Yes,
competent, and then they'll be more motivated and comfortable.
for sure. Yeah.
Yeah. So, and you mentioned like the legal aspects and ethics and consents and privacy law. Like, are there particular competencies that you want to mention that you think would be are also important for couple and family therapists?
Sure. So I think one of the more important ones is, and maybe easier for students to sort of get at this point, would be the virtual environment and telepresence piece. I think it is easy to do well. And if it's not there, it can be very, very distracting for a client. So
Uh,
the objectives of that domain, when we have our telebehavioral health competencies, they're divided into domains. Each
mhm.
domain has an objective, or several objectives rather, and then we
Uh-huh.
talk about how to execute those objectives. So that's kind of the layout of the competencies. In
Yeah.
the virtual environment and telepresence, you have to make sure that you have a therapeutic environment that is as close as possible to an in-person environment. I
Mm,
have to pay attention to what might be behind me that's distracting. I've had
right.
some clinicians who just kind of have a blank wall behind them as to not be distracting, but oddly enough, the blank wall is distracting.
Yeah, that's right. It very well
Like,
could be.
am I in a crazy house? Like, what's happening? Right?
That's right. If it's strange, it's odd.
Looks a
Yeah.
little strange. Yeah. Yeah. I had another student just recently I thought this was brilliant. She had a candle burning kind of off to the side. And the first thought I had was, what's the point of that? I can't smell that
Ah,
because and then I thought,
right.
oh my gosh, it's brilliant, because I could actually feel the warmth of the candle, even though I wasn't even there. It set
Nice.
a mood, and it was really, really smart. And I told her that. I said, I've never even thought about doing that, but that's completely brilliant, right? So
Yeah.
people who are proficient in that are using the technology so they can optimize the information so that couples can organize their space to have a really a session that's conducive to their goals, right? They have to make sure that we can hear them, they can hear us. I know that clients sometimes sit in a car because there isn't any other place to be able to conduct the session, but I don't like that. I don't feel like that's private. I don't feel like that's warm, right? I think that both the clinician and the client need to set up their space to make sure that it's going to be a place where we can hear you, where we feel like we can observe important behaviors. If there's glances or someone getting emotional, it's private, it's warm, and it's going to support that alliance. So making sure that you as a clinician are paying attention to what's going on back here, that it is the space that you would normally have if you were in an in-person setting, and that we as clients to also find ways to create that for themselves as well. Okay. So distraction free is important, making sure that you have appropriate lighting. When you're working with families, you've got to deal with multiple people in the room. And so sometimes in telebehavioral health, we'll have people sort of all sitting on the couch all at once, right? All like next to each other, which I don't know about you, but when I do family therapy, one sitting on one couch over here, one sitting on the other couch over here, right?
Right. Right.
It's going to feel
Yeah.
different to the family. So we have to make sure that we are, again, educating them on how to set up the machines so they can sit comfortably as if they would do in session, right? Maybe I don't need to
Right.
see like their direct face like this. Maybe I can live with them sitting back a little bit, right?
Mhm.
Because I can now more easily see their partner or their child in a way that is going to be more accurate to how
Mm.
they would present in person. right?
Right. Yeah.
Also, I think it's about making sure that the family might have white noise devices or things to kind of blur the sound. I was working with someone who was seeing me while he was in his office, and I think probably he would turn up a radio, right, just to make sure that his office staff couldn't hear him during the session. So that was sort of his way of dealing with it, turning up a radio, turning up some white noise, but making sure that your confidentiality is protected is very, very important. You could also do a multi-point video camera system that would better help you be able to approximate the real world experience. So you'd be able to see people from different angles. There are very few clients who are going to have multiple cameras in the room, right, where they're located. But and there may be even families that don't have the internet bandwidth to support streaming on more than one device. So maybe another way that people have solved this is going, well, we'll just put everybody in their own room with their own device, but maybe there isn't the bandwidth to be able to accomplish that. So
Right.
we have to really think about what are the capabilities that we have, how do we set up the scenario, because that's going to go a long way into how that session feels for both you and for the client.
Right. Yeah, definitely. Definitely. Those are very helpful hints. Yeah. And being a researcher, what's some research that you want to get to in regards to this?
I would love to know a little bit more about the family's experience of it, because I don't think we have everything worked out in terms of where people sit, how they sit, their level of comfort in the room. I want to know what is the optimal sort of setup for multiple people in a room. Is it better to have sort of one camera where people are spread out, or do we in fact make everybody sort of cram on a couch and kind of huddle around one device? I want to know more about that. A second thing is I am really curious about the ability to do TBH in a play therapy manner and its effectiveness. I love play therapy. I practice play therapy. When the pandemic hit, I found it almost impossible to do. And I'm certain there are people who know how to do it, know how to navigate play therapy. And there are websites where you can say, here's things to do with play online. But it is so different because I think I'm such a purist when it comes to play therapy. For example, you're not supposed to have dolls in a room that mean anything. I was working with a kid last night in person, and he said to me, do you have any Marvel characters in here? And I said, no, I don't have any. First of all, I'm a Wonder Woman fan, so no Marvel characters in here. Okay, I'm pretty sure it's a DC. So that's okay. It's not going to happen. But I do know that from a play therapy perspective, we're not supposed to have any toys in there that mean anything in the outside world. We're supposed to have toys that don't have any meaning, that are kind of a blank slate, and let the kid put their impression and their experiences onto those toys, right? So when you're doing play therapy, you can't control the environment in TBH. And so I've got kids walking around the room playing with their dolls. And I'm learning ways to be able to try to do TBH with their dolls, which I think are inappropriate because they mean something to, right? Like Barbie means something. This means something. Like, I don't like that. Or, I know that you have to have like certain markers and certain things are I think basic in a play therapy room. And your kid doesn't have those in their house. And another kid, she would take me on tours of the house every day, which were great. That's fine. That's cool. And then I had a hard time getting to her dad because he would be in another room. He and I would agree to talk at some point in the session, but he let her sort of run the session. She was 7. And so she would do things. I would be like, okay, go get your dad. And she's like, no. And I'm like, okay, really, go get your dad. And she's like, no, I'm done. Bye. And she would just close the machine. And I'm just like, okay, like that wouldn't happen in a room, right? So I really want to know what are some of the best practices and how effective are we really being conducting play therapy online? Because I think it's really hard to do.
Right. Yeah. Yeah. There's so much research that could be done. So I'm glad that you're a researcher and you do research. Yeah, because I agree. The more we can find out about these things, the better. And really doing some good, solid research on this stuff is so helpful.
Yeah.
One thing that's a little difficult about research and is that it looks on the aggregate level, and people are individuals. And like you mentioned earlier, people have different access to the internet, different bandwidth, different technology available to them. They have different preferences, different comfort level. Yeah, so that makes it a little bit challenging, but the research is super helpful. I agree. Yeah, so thank you very much for all the work that you do. And I encourage everyone to read that article. Again, it's toward proficiency in telebehavioral health, applying interprofessional competencies in couple and family therapy. And the link to that will be in the description. So thanks a lot, Dr.
Thank you.
Hertlein. Appreciate it.
Yeah, nice to meet you.